not only placenta previa, but a woman who's had a previous myomectomy, adherent placentas are very common. So when we scan a woman who's had a previous myomectomy, it's very important to localize the placenta and see if there's any adherent placenta. Malpresentations like breech are fairly common. So all these, because of placenta previa, because of malpresentations, because of prematurity, automatically the cesarean section rate is high when you have multiple fibroids. And remember, again, all these causes leads to increased postpartum hemorrhage. So in managing a case of fibroids, we need to anticipate this cross-match, keep blood ready, especially when you're doing a cesarean section, because you may be taken by surprise by massive postpartum hemorrhage. The cesarean section rate, if you compare a fibroids with no fibroids, it's almost 2 to 3 times higher. Malpresentations are again 3 times higher. Labor dystocias, PPH, are also double that of normal. Why do we have preterm delivery? We said yes, because if there is placenta which is adjacent, when there are multiple fibroids, there is decreased oxytocinase activity. So this leads to reduced activity of this leads to increased oxytocin. This can start premature contractions and overdistension. Again, abruption, we said it's increased. This is more common when there are submucous and retroplacental fibroids, and there are large fibroids more than 200 centimeters. Placenta previa, again, we said higher incidence, malpresentations. What is the effect of fibroid? Will they cause congenital abnormalities? No, there's no evidence to say that fibroids cause any congenital abnormalities or pressure effects or growth restrictions. What is known is prematurity. So apart from prematurity, there's really no impairment of fetal growth or no abnormalities or no pressure effects. But what we have seen is adenomyosis certainly causing some pressure problems. We've had one case of hemiatrophy of the face. We really do not know. But even on scan, you do see that the adenomyosis does cause a lot of compression compared to a fibroid. Postpartum hemorrhage, the woman is really at a very great risk, especially if it's retroplacental and she has a cesarean. That's because, again, of uterine atony. So we need to be prepared. What are the indications when you have fibroid? Does every woman with fibroid need a cesarean? No, the indications are malpresentation, previous myomectomy where the uterine cavity was opened is certainly an indication for a cesarean section, or if an obstructed labor, like a cervical fibroid, a subserous fibroid, which is impacted in the pelvis below the presenting part, again is an indication for cesarean section. Your hands itch when you have a fibroid and you're doing a cesarean section. Is there a role of doing a myomectomy? Which are the fibroids we can remove during a myomectomy? Dr. Piley is a proponent. He says, yes, this is the time where you can. He says the blood loss would be less. She does not have to undergo another surgery. So he's a strong proponent. But Dr. Piley's experience, his surgical skills, I don't think any of us have doubt. But there are clear indications where you could resort to what is called a selective myomectomy. This is not routinely done because there is a heavy high risk of hemorrhage. So you could do selective cesarean myomectomy where there are pedunculated fibroids. All you can do is clamp and remove that fibroid. There are subserous fibroids which you feel you can enucleate very easily, and a fibroid which is in the lower segment, where if you are cutting, if your line of incision is in this, you're going to end up with massive hemorrhage. The only way to avoid then would be to do a classical section, which again further deteriorates her reproductive outcome. So if you have to take a choice between a classical section and enucleating this fibroid and going through a lower cesarean segment, these would be the real indications where you may end up in doing a myomectomy during cesarean section. And this certainly obviates the need for an interval myomectomy. There was a large study involving 1,242 women where they did a myomectomy at cesarean section, and they divided, compared to this 1,242, there are 3 other groups. Group A consisted of 200 women where there was no myoma, but this woman underwent section. Group B, where there were myomas and cesarean section, but no removal of fibromyomas. Group 3, myomas who needed a hysterectomy during cesarean section. And what did they find? They found that there is no difference between pre and post-operative hemoglobin levels. That means there was not much of bleeding between all the 4 groups. The blood loss, blood transfusion, post-op fever, duration of operation, or length of hospital stay, all were same. But I'm sure these were real experience who planned it well ahead. So a word of caution, we really know that there could be need for blood transfusion, and every effort should be made to avoid performing a myomectomy at the time of cesarean delivery, especially if there are intramural or submucous, because there is a risk of severe hemorrhage which needs blood transfusion. You have to be prepared for uterine artery ligation and may end up with puerperal hysterectomy. So there is a word of caution, but there are selective indications we could restrict to those indications. What is the effect of fibroid and the puerperium? How does this woman behave? Are there any special precautions that we need? Retained placenta is very common, especially if they are retroplacental fibroids. The incidence is about 1.4. Subinvolution is fairly common. They may end up with secondary postpartum hemorrhage. This happens especially with submucous fibroids or fibroid polyps. There could be inversion. If there is a fundal submucous fibroid, as the uterus is involuting, it may end up in an inversion, and certainly there's an increased incidence of puerperal sepsis. So how do we manage waiting for these complications? Yes, we need to be aware that there could be retained placenta. Certainly give these women antibiotics, watch for fever, watch for excessive bleeding, and be prepared. Is there any chance of malignancy? The chances of malignancy itself in a fibroid overall is very less. The incidence of malignant degeneration or changing into fibroid is less than 0.2%. There could be de novo leiomyosarcomas, but as such, fibroids undergoing malignant change is fairly less. There is one other entity we need to remember is benign metastasis leiomyoma. Though they are benign, they are known to metastasize. This is a very, very rare entity, originates from antecedent leiomyoma of uterus. We had one case where after a hysterectomy, we found these in the peritoneum in the lungs. The tumor metastasizes to lung or extrauterine connective tissues via the hematogenous. There's only one case in my past 25 years where we had this. She suddenly, after hysterectomy, she had a large, again, recurrence within, I think, less than 3 months and in the lungs. Having said that, once a woman has delivered, what do we do? How do we handle this? We have handled the puerperium. What do we tell her? Does she need surgery at the end of it? What are her options? So what are the issues once we say, yes, you need to have a myomectomy before you plan another delivery? What are the issues that we discussed with her? First of all, do we need to? If she's had a term delivery, no PPH, nothing, baby was fine, do we really need to remove this at all? Is there any benefit when you remove it? Is there a potential for conception? No, she's conceived. Within 3 months of marriage, she's conceived. So is there really a need? Are there any less invasive alternatives? If she had menorrhagic cycle, she was anemic, do we give her any options? What is the impact? If you do touch her, what will this do to her future fertility? You may produce more additions and land her in a bigger problem. Then, is there a need for additional procedure? Will she need another procedure? She showed a beautiful graphs, whereas in the next 10 years, she will again have another fibroid, so you need to tell her that. And when you do a myomectomy, what is the risk that this woman has of a uterine rupture in her subsequent pregnancy? Will she actually conceive because of additions? And what are the best approaches? So unless we raise these issues with her, do we really do it? If we do, what is the procedure? When do we do it? What is the impact on future fertility? What is this impact on future pregnancy? Unless we discuss these, I do not think we can just give her a choice.